Okay, well, we're going to talk about lung cancer screening today. Some of you in the audience may have seen some of these slides, but hopefully it'll be interesting. And what we're going to do is we're going to talk about lung cancer screening here at Alamance, and then Sean Perkins, who is our nurse navigator for thoracic oncology, is going to spend the last 5 minutes or so talking about how do you actually go about getting screened for lung cancer. I mean, who do you actually call? What phone number do you call? So if anybody in the audience is interested in having a lung cancer screening, he'll let you know how to do that. Okay. So I'm one of the cardiothoracic surgeons here at Alamance. Actually, I guess I'm the only cardiothoracic surgery at Alamance. Can we turn the lights down a little bit? Well, this is what lung cancer is, and this is what you don't want. Here you can see this is the trachea, the main windpipe, leading from the larynx up here down into the lungs. This is the right main windpipe. This is the left main windpipe. This is the tumor. As you see, it occupies half of this whole left lung, and all these are lymph nodes. There's other tumors in the lung over here and here. Obviously, this is not a good situation. So this would be very advanced lung cancer for which there's very little hope. Now, I passed around at the beginning of this, there's an exam. Okay, did y'all take it? No? What have you been doing? Eating. Okay, well that's a good excuse. So was I.
We thought it was at the end.
Well, it's a pre and post to see if you learned anything. Okay. It'll be a reflection of my ability to teach. So if you got any wrong at the beginning and you get them all right at the end, then I've done a good job. Okay. Do we need the lights to look at the thing? No? All right. Yes? All right, let's turn the lights on for a little bit. Okay, well, let's talk about lung cancer then. Here's some information for you. This is the number of estimated new cases of cancer here in the United States. This is based off of data from 2015, so this is current. This is as of today. And if you look at the number of new cases, here males and females, and then over here is the estimated deaths. That is how many people are actually going to die from the disease. So if you look here in males, the most common cancer in a male is prostate. Females don't seem to have any prostate cancer. I wonder why that is. But if you look here, breast cancer is the most common cancer in women. But look here, lung and bronchus, also pretty common in males and females, and colon and rectum down here, bladder, uterus, etc. But if you look at the estimated deaths, you'll see that more people die of lung cancer in both males and females than breast, prostate, and colon combined. So even though there's not as many lung cancer cases, there's more deaths due to lung cancer. Now, I bet everybody here knows, what the, everybody here knows what those little pink ribbons stand for. As I look over the audience, most are women, but, and it's appropriate that we spend a tremendous amount of research dollars and societal impact on trying to influence breast cancer. But if you actually look, only, and I use that word, 40,000 people will die of breast cancer, but almost 70,000 women will die of lung cancer. So twice as many. But you don't have any ribbons for lung cancer, and we don't hear a lot about lung cancer. We hear a tremendous bit about breast cancer, though, and prostate cancer, but lung cancer is sort of forgotten. And it's unfortunate that that's the case because it is really the single leading cause of cancer deaths in the United States. Why is that? Smoke. Yeah, but why do we ignore it? Why don't you hear about lung cancer screening? You're here today to hear about it, but this is probably the first time any of you in the room have heard about it. Everybody knows about a mammogram. Everybody knows about getting a prostate exam.
cigarette companies don't need it.
Cigarette companies, what do they say?
They probably
They
don't
did
want us,
not.
they don't want you to learn about lung cancer.
Well, that may be the case, yeah.
They won't
With
still
me,
sell
it
cigarettes.
bothers me is that you never catch it. You know, people don't get screened and you don't get it to it so late.
Yeah, well, that's what we're here to we're trying to figure all this out. I don't know the answer to that, but having done this now for 25 years, most patients who come to you are smokers, and we're going to talk about that in a minute. And so most people say, well, if you hadn't smoked, you wouldn't have this problem. So we all know that breast cancer is not something you don't influence it. You know, many women are going to develop it. Many men are going to get prostate cancer. They didn't cause it. They're just unlucky. But we all know that smokers cause it themselves, right? So it's their fault. If you hadn't smoked, you wouldn't have gotten it. And that kind of attitude really permeates society. And it's really unfortunate because these people deserve our attention, they deserve our health care. So I really try to take a good history, but I never try to tell the patient, well, you know, smoking probably caused this. We all know that that's the case. You'd have to have your ears closed for the last 50 years to not know that smoking is the cause of lung cancer. So they don't need to hear it again. What they need is they need sympathy, they need support, they don't need criticism. But unfortunately, we're all too willing to heap criticism upon some of those patients.
And put blame where it doesn't belong.
And put blame where it doesn't belong. So,
What about, I'm sorry, what about patients that don't smoke and develop?
yeah, we're going to get to that in just a
Okay.
second. Okay, so here's the take-home message. More people die of lung cancer than breast, prostate, and colon combined. All right, I just said that. Lung cancer is the leading cause of cancer deaths in the United States, with more people dying of lung cancer than breast, colon, and prostate combined. Now, we already have a screening protocols for breast and colon, prostate. You know, I turned 50, I'm not going to tell you how long ago, but I had to get a colonoscopy. Well, I mean, I'm not likely to die of colon cancer. I'm more likely to die of lung cancer if I were a smoker. My wife gets mammograms every year. I get a prostate exam every time I go to the doctor. I'm glad Dr. Klein has small fingers. But we don't do anything about lung cancer. And it's a shame because it is a deadly disease and it's something that we know a great deal about. Okay, well, another way of looking at it. These are estimated cancer deaths in 2013, so pretty recent data. If you look, 28% of all cancer deaths in men are going to be from lung cancer. Women, 26%. Only 14, again I say only, I don't really mean only, but 14% of women who die of cancer will have breast, but 26 are going to have lung cancer. But we don't have any ribbons for lung cancer. So it's a deadly disease. It affects both males and females. It's a significant health care issue. It's not just a problem of a certain group. It involves both males and females. It runs the spectrum. And if we could reduce the incidence of lung cancer, that would be a great societal benefit. We spend millions and millions and millions of dollars for seatbelts. And that's appropriate, we should. But we don't spend a whole lot of money trying to prevent and screen for lung cancer. So I just say this only because I just want the impact I want you to walk away with is just recognizing this is a real problem. It's a real problem that we need to deal with, not just me and you, but all of us. The whole society needs to deal with it. And what's amazing is we have a tremendous amount of information about this disease. It's not an unknown. We know how to fix it. We know how to screen for it. We know how to treat it. We know who gets it. We know what the causes are. But we don't do much about it. Well, who gets lung cancer? Smokers. Smokers, people who smoke. We know that, okay? So that's the single greatest risk for developing lung cancer, and approximately 90% of people who develop lung cancer will have a smoking history. So 90% of the time, people who smoke, people who develop lung cancer are smokers. We also know that people who are exposed to secondhand smoke are also at a higher risk. So if your spouse smokes, or if your parents smoked in the house and you were exposed to that, you're at a higher risk for getting lung cancer. If you have radon exposure, anybody here buy or sell a house recently? You have to get a radon test. Why? Well, who cares? What's radon? Well, radon's a gas. It comes up out of your basement. It's in your foundation, and it causes cancer. It's inhaled into your lungs. And right now, it's estimated that 10% of all lung cancers are caused by radon exposure. That's 10%. That's 25,000 deaths a year from lung cancer caused by radon. Yes.
Does it have an odor?
No, it's odorless. You have to test for it. You have to put some sort of a machine out in your house to measure it over the course of a couple days. But if you go to buy or sell a house in the state of North Carolina, you have to be tested for radon exposure. And the reason is that if it's high, then you have to put in a radon scavenging system, which is basically a giant vent underneath your house to suck away the radon that's coming up through the foundation of your home.
But is radon just normally in the soil?
Radon's everywhere, but there are certain places where it's higher than usual. Just like right now, we are constantly being bombarded by ultraviolet rays, radiation, right now as we're sitting here. We're also inhaling radon. But if we were in a high radon area, you might be exposed to that and it could cause lung cancer.
I have a question about radon. So, is it in dirt or does it come from minerals, rocks?
It comes from rocks. It's trapped in rocks. And it leaches out over time. And if you have a new construction where they turn over the dirt and they break up the rocks, it's higher than if your house has been sitting there for a long time. It's higher in certain parts of the country, just like coal's more common in Pennsylvania and West Virginia than it is in Nevada.
So is it a certain rock or?
I don't know the details of which rock it might be in, but it's all over the country. But there are certain pockets of it that are higher, where it's higher than usual.
So if you live near a rock quarry where they're busting
It may be higher, yep, maybe. It may not be. I mean, you may be in a radon poor environment in which you could live underneath a rock quarry and it wouldn't hurt you any. But I just want to tell you though that 10% of all lung cancers are caused by radon. You never heard of that before. That's 10% of 250,000 deaths. That's 25,000 deaths a year caused by radon. Asbestos exposure. Everybody knows, you see all those commercials for mesothelioma. Call Mr. Sokoloff for your law consultation. We know that asbestos is used in many different industrial uses. Anything from brake dust to insulation. Maybe your homes have asbestos in it. We use the word asbestos pretty loosely. All insulation is asbestos. And my dad still says, oh, I put some asbestos in the house the other day. Well, I know it wasn't because asbestos has been outlawed for years. But there's still asbestos around, and if you go to some older homes, you may well have that. And we know that asbestos causes not only mesothelioma, but it also causes lung cancer. Yes?
So asbestos exposure from brake linings.
Yep.
Right? So we're all located here along the major interstate.
Yep.
Do the fibers or the dust, are they heavy? Do they settle?
Yeah, they
quickly,
settle.
Or do they get dispersed easily?
No, it's a mineral. It's like quartz or gypsum. It settles out onto the dust. But you're correct. I mean, you're inhaling asbestos right now.
Right.
So am I. We all are.
And I guess it settles in Lake Camac too? Like I'm saying, I'm wondering how far it travels. Or does it pretty much
go all over the world. All gets picked up by the dust and blown around. It's all over the place, yes.
if you have,
But we haven't even gotten beyond the third slide yet, you know. Okay.
if you have mild asbestos, what are your chances of getting lung cancer?
Okay, we'll look at that in a minute, I think. No, I think I took those slides out. What is your chance of getting lung cancer? I thought if you smoked all your life, your chance of getting lung cancer would be 100%, right? It seems that way to me. About 16% of all people over the age of 70 who smoke at least 50 years will get lung cancer. Now what that means is 84% don't. But that's not a reason to smoke. If, you know, you're not going to roll the dice and hope you're one of the 84%. But we know that smoking causes other problems, you know, it causes strokes and coronary artery disease and aneurysms and hypertension and all kinds of other stuff. But so we know that smoking is the most common cause of lung cancer. We know that exposure to asbestos and radon also are small contributing factors, but it would be relatively low, I guess is what I'm trying to say. Because only 16% of people who smoke for more than 50 years will get lung cancer. You know, I mean, I've had people say, well, you know, I knew I was going to get it, but I'm 83 or I'm 87 or I'm 79. I'm okay. I've enjoyed my cigarettes all my life, and that's the way they feel about it. But, you know, my mother still smokes. She's 82. She smoked ever since I was a little kid. I suspect someday she'll have lung cancer. She has a 16% chance of developing it. So every time the phone rings, I think it's probably her telling me that the doctor found something. But, you know, that's what she says. She says, I've enjoyed it, I've needed it, I've wanted it, and I've enjoyed it all my life. All right, environmental exposures. Well, we know that people who work in coal mines are exposed to all kinds of things, from uranium that's trapped in the coal to radon and other particles. People that work with certain chemicals also are at a higher risk for lung cancer. Okay, this is important for you all here in the audience, radiation exposure. So women who have breast cancer and who opt for some sort of radiation therapy as part of their treatment plan get a very high dose of radiation, not only to their breast, but what's underneath their breast, and what's underneath there is their lung. And so many women, again, I don't know exactly how many, but I see them every year. Many of them will have had prior radiation exposure to their breast, and then 5, 6, 8 years later develop lung cancer in the radiated part of their lung. Remember, when you think about what happened, you know, fortunately, hopefully we'll never ever experience this again, but at the end of World War II, when you look at what happened with all the nuclear fallout in Japan, tremendous amount of radiation exposure. While we're doing the same thing, but on a medical for medical reasons and with more guidance when we treat people with breast cancer. We're giving them tremendous doses of radiation to kill the tumor and hopefully cure the patient. But that does mean, though, that their lung, which is underneath of them, is being exposed to very high doses of radiation, which we know is cancer causing. Many people who died after Hiroshima and Nagasaki didn't die until 5 or 6 or 10 years later from their cancers. Yes?
So you're saying that the cancer that they get, the women who were radiated, breast cancer, it's not breast cancer that is metastasized, it's actually lung cancer.
It's lung cancer. Okay. It's not breast cancer.
What about prostate, men that have prostate radiation, they get lung cancer?
No, because the radiation field is directed to their prostate.
It's limited to
yeah, it's just limited to the prostate.
What about if you've had throat cancer?
Yeah, if you've had throat cancer, the same thing, because it would also be included in those radiation fields. You know, I don't remember this, actually. I may look old, but I'm actually not that old. But I do remember, though, my parents saying that a lot of people my age when I was a teenager got radiation therapy for acne. Anybody remember that? Okay, I don't, but that was a little before my time. But many of those young kids then went on in their 30s and 40s to get thyroid cancer because of their exposure to their face to radiation. And I don't know if you know this, but you know, Madame Curie, who was one of the main discoverers of radiation and all that, she died of cancer from being exposed to radium. Okay, and finally, genetics. So if you have a first-degree relative who's had cancer, then you are more likely to get it too, even if you have no other risk factors. Now, again, the risk is not all that high, so if you have a brother or sister who's developed lung cancer, don't freak out, unless you have other risk factors like smoking and other things. But we do know that people who have had cancer in the family, though, they are at higher risk. But by far and away, the single greatest risk factor is smokers. Well, not everybody who develops lung cancer is a smoker, though. And if you look, for example, people who develop adenocarcinoma of the lung. What is adenocarcinoma? Well, that's just one of the subtypes of lung cancer. But you can see that a fair number of them have never smoked. You know, maybe about a third or a quarter of all patients who develop adenocarcinoma. And if you look over here, a small cell carcinoma, which is again another type of lung cancer, only 1% of the people who develop small cell have never smoked. Squamous cell, maybe 3 or 4% have never smoked, but yet develop lung cancer. And in fact, lung cancer has been discovered in Egyptian mummies. They didn't smoke, at least we didn't find any packs of Marlboro in their tombs. So not everybody who develops lung cancer is a smoker. And that's one of the problems with lung cancer screening, is that if you only screen people who smoke, well, what about this group of people, and that group, and that little group, and that group? You're going to miss those folks. We'll talk about that in a minute. Okay, so why do we even worry about all this? Well, we know that for screening purposes, we know that the stage of the disease, which means how aggressive has the tumor been, has it spread to other locations, does it involve the lymph nodes, or is it spread to the lungs, to the liver or somewhere else, that determines the prognosis. So if you want to make an impact on lung cancer, you better find it early while it's still in the lung and localized, not when it's advanced, where, like the picture I first showed you, that's not, finding that patient is not going to really improve the outcome. We want to find it when the tumor is really tiny and small so that we can treat it. And this is true of almost all tumors. In fact, when I made this slide up, I was trying to think, was there a tumor? It's not true, and I can't think of any, but I'm not an expert in everything. So I don't know that, but I suspect it's probably true that anytime you find a tumor earlier is better than finding it late. And so we think that if we find the tumor at an earlier stage, it'll improve overall survival. So what are the chances of being cured of lung cancer? Well, here's the survival by stage. So stage 1 is good, stage 2, stage 3 not so good, and stage 4 pretty advanced. If you look, and they're divided into 1A, 1B, 2A, 2B, 3A, 3B, and 4. So if you look at stage 1A, your chance of being cured of lung cancer at 5 years is about 50%. So that means if you have an early stage lung cancer, a tumor that's small, hasn't spread anywhere, located in the lung, picked up, incidentally, just a little tiny thing, and you take it out, or you do something to treat it, you have about a 50% chance of cure. Well, that's not so good. I wouldn't want those odds. I want a 99. I want a 90. And so when I counsel patients, and they, particularly, this happened to me yesterday, you go out and talk to the family, they say, did you get it all? And you say, well, I think so. It's just in the lung. It didn't involve any lymph nodes. Oh, well then, mom is cured. Well, you're thinking, well, I don't want to be brutally honest, but I want to tell you this is going to require long-term, lifelong follow-up with me, because I know that half of those patients are not going to survive. So the goal is, though, that's better than 2%. So the goal that we're trying to do is we're trying to find all these stage 1 cancers, which is good, and we're trying to avoid all those stage 3 and stage 4 cancers, which is not so good. So we do know a great deal about staging, we know about prognosis, and we know what causes it. We've got a lot of technology, so therefore we must have made some great strides in treating lung cancer, right? Not really. The 5-year survival, that is your chance of living 5 years after the diagnosis has been made, has gone from 12% to 18% over the last 30 years. So that means 30 years ago, if someone said, I've just been diagnosed with lung cancer, you could say, you have a 12% chance of living 5 years. Today, if someone comes to you and says, I've just been diagnosed with lung cancer, you can say, well, you have an 18% chance of living 5 years. Now that is an improvement, and every improvement is beneficial to society and to our patients. But it's not exactly the kind of improvement we were hoping for. Let me show you the data. This is a really complicated slide, and I'm going to show you just bits and pieces of it. But this is data going back to 1975. And if you look, in 1975, if you were diagnosed with lung cancer, you had a 35% chance of living 1 year. 5-year chance of 12%. Now move all the way forward here to 2010. It's gone from 35% to 45%. Well, that's a good, we're glad to see we're making improvements. But it has not gone from 35 to 95. And likewise, the 5-year survival, you can see, is sort of coming up a little bit, and now we're at 18%. Just to make it a little more easier to look at. In 1997, you had a 40% chance of living 1 year. Now you have a 46% chance of living 1 year.
And this is at stage 1?
These are all patients. All patients who develop cancer of the lung or bronchus. All patients, males, females, whites, blacks, Native Americans, Hispanics.
Why is that, Dr. Oaks?
Well,
Why is the percentage so little?
why do you think it would be?
Screened, not screened like it should be.
When do you go to the doctor for your lung cancer?
Until you have it.
After you have it, right? When do you go to the doctor for your breast cancer? Every year I go and I get a mammogram. When do you go for your colon cancer? Well, every 5 years I go and get my colonoscopy because of screening. We don't screen for lung cancer, but we are now. I'll tell you about that at the end here. So clearly, prognosis is related to the stage at which the cancer is discovered, and therefore screening for lung cancer may find incidental tumors when they're at an earlier stage and therefore better to treat. What about a chest x-ray? Again, my mother says, oh, I went and had a chest x-ray and it was fine. I'm like, Mom, that doesn't mean a thing. Because tumors have to be pretty darn big to show up on a chest x-ray. And by then it's already, the horse is out of the barn. What about a CT scan? Well, yeah, that's a good thing. But CT scans now are so good, they pick up every little tiny dot. And if I get an x-ray on everybody in this room, I'll bet every one of us is going to have something wrong on the CT scan. There's going to be some dot, some nodule, some shadow, something on it. So a CT scan is very, very sensitive. It can pick up things as small as 2 millimeters, which is about the size of a grain of rice. We don't know of any blood tests detect for lung cancer. We do have blood tests for colon cancer, for breast cancer, for prostate cancer, but we don't have any for lung. They just don't exist yet. They might. So, what is an ideal screening test? We're talking about, you're here to learn about lung cancer screening. Well, what is it? What should it be? Well, first of all, the disease in question must be a healthcare problem. We don't screen for hemorrhoids. Well, why not? Well, because it's not really a healthcare problem. I mean, it may be to you, but it's not a societal problem. We're not going to spend billions and billions of dollars to screen for something that really doesn't have a tremendous impact on society. There must be a defined population to study. You can't screen neonates to octogenarians. There's got to be a certain people that get it. So we know who that is, right? We just saw that smokers, we thought. The test must detect the disease at an earlier stage, allowing for more effective therapy. So we could, it wouldn't be that expensive to screen all people with a chest x-ray. They're not very expensive and it's relatively easy to do, but it's not very good. And so it's not going to detect the disease at an earlier stage. That's been shown many, many times. It has to be inexpensive. You can't spend $1 million for every single person in the United States. We just don't have it. So it has to be inexpensive and it has to be available to everyone. It's not something that you can only get at Alamance but you can't get in Greensboro. It's not something you can get in North Carolina but can't get in South Carolina. It's got to be something that's readily available. And it has to be safe. And it cannot cause any harm. So all of these things are like the ideal test. Well, what about mammography? Okay, we know who the defined population is. That's women over the age of 40. And then you get your first mammogram, then you come back, I think it's what, 45, and then 50, and then it's every year. So we got that figured out. We know that's a healthcare problem. Breast cancer is a real healthcare problem. It does detect the disease at an earlier stage. That's why we do it. That's why most of the women in the room here go through it. It's relatively inexpensive. I mean, if you're paying for it out of pocket, it's not a pleasant thing to do, but it's not $1 million of test. It's readily available to everyone. Anybody in this room could have a mammogram done by the end of today if I really wanted it. Is it safe? Does it cause any harm? Well, it hurts a little bit, my wife tells me. I've never had one. Is it safe? Well, we think so. We don't think it causes any problems. So we have these things for breast. We have them for colon. We have them for lung. I mean for prostate, but we don't have them for lung. Now the test must also show a high degree of sensitivity. What does that mean? Well, that means it has to be truly positive. That means if you have the disease and you get the test darn well better pick it up. If it doesn't, then it's no good. But it also has to be highly specific, meaning it's truly negative, meaning, you know why we don't use those those hemoccult cards anymore? Remember you used to have to go take a little stool sample and put it on there and put the little reagent on the back of it? Because every time you had a hamburger, it was positive. And so, if you ate red meat within the last month, it was positive because there was a little blood in that meat. And so, that we sort of said, well, you know what, the doctors were just getting inundated with phone calls saying, I did my stool guaiac test and it was positive. Do I have colon cancer? Well, no, you had a hamburger yesterday. So we've done away with that test because it's not very sensitive. A lot of people had positive results who didn't have colon cancer, and a lot of people who had colon cancer had a negative study. So we did away with it. It really wasn't all that beneficial. And then finally, you have to have some skilled medical personnel who can take care of the problem once you identify it. If you identify the problem and then there's nobody who can manage it, well, what was the sense of identifying it? You got to have people who can manage the problem if you're going to look for it. So if you're going to order a test, then you better have the people available who can take care of that problem. So, since World War II, in the late 1940s, people started looking at lung cancer because really the incidence of lung cancer really went up in the 1940s. And it takes years to develop lung cancer. So smoking sort of took off in the 30s and early 40s. And then by the late 40s and early 50s, a lot of people were developing lung cancer. And people were saying, whoa, what's going on here? Why is this? What's happening? But we've known that cigarette smoking and lung cancer have gone hand in hand for many years, but the tobacco industry refused to admit that. But there's been trials done and there's been things done to look for lung cancer, but really all these studies were very, very flawed until the early 2000s when this thing came out called the National Lung Screening Trial. The National Lung Screening Trial enrolled over 50,000 patients and looked and compared half the patients got a CT scan and half received a chest x-ray. And then patients received additional studies 1 year later and 2 years later and on and on. And 50,000 people is a lot. So when you go, if you're interested in this and you go and look up the literature, you may read a study from the University of Minnesota where they looked at 240 people. Well, it's, 240 patients, something that statistically you don't have the same degree of confidence in the study if you only have 240 versus 53,000. So if it happens in the 53,000, I think you can pretty much say that's a pretty good sample of patients. And what we did was I was part of this national lung screening trial. We followed these patients until 2010, and then in August of 2011, these results were reported. And then once they were reported into the medical community, they sort of trickled down to the lay community. In 2012 and 13, a real uproar began to occur. People began, calling their senator, calling their representative, hey, why is Medicare not covering this? Why is my insurance not covering this? And so now we're at the point where Medicare has finally agreed. But here's what was found. There was a 20% reduction in lung cancer-related deaths in the group of patients who got a CT scan compared to those that got a chest x-ray alone. So what that means is that, sure enough, the CT scan did pick up more lung cancers at an earlier stage than the chest x-ray. We knew that. And we found a 20% reduction. Well, that's pretty amazing. That's really good. I mean, it is. In addition, there is almost a 7% reduction in the rate of death from any cause. Because if you got your CT scan, oh, by the way, you got an aneurysm, you better go get that fixed. Oh, and you got a kidney tumor too, by the way, now you get this one picked up. So what it was basically saying was that if you get a CT scan, you might find something wrong with you that might be able to be cured. Now the problem is, who goes and gets a CT scan every week? How often do you need it? Who's going to pay for it? But here is the problem with the study. 96% of all the positive tests in the CT scan group and 94% in the chest x-ray group were false. That means that if you took 100 patients who had some abnormality, 94% of them were going to turn out to be nothing. 6% of them were going to be lung cancer. So what do you do with that information? Well, that's not exactly what we wanted. We wanted 100% of the positive studies to be representative of the disease that we're looking at, and not all these false positives. Meaning, the doctor said that he saw a shadow on my CT scan. Do I have cancer? Well, again, just statistically, I can say 96% of the time you probably don't. But how do you know if you're that 4 out of 100 that actually do? Well, that's where people like me come into play. Hopefully there's a job for me. All right, so here's what was found. This is the data. So here's the number of lung cancers. So in the low-dose CT scan group, you can see that over the course of time, we found a lot more lung cancers than we found just based upon chest x-ray alone. And the reason is that the CT scan picked up little tiny lung cancers that we didn't even know about. Whereas the chest x-ray, the thing had to get pretty darn big before it showed up. So we found more tumors in the CT scan group, but here's the number of deaths from lung cancer. If you look at the number of deaths, you see more people died of lung cancer who were in the chest x-ray group than in the CT scan group. So you picked up more tumors in the CT scan group, but less people died from the disease. So all in all, pretty good thing. So what about this CT scan? Did the CT scan detect cancer at an earlier stage, allowing for more effective therapy and/or cure? Sure did. Did it have a high degree of sensitivity? That is, the number of truly positive studies out of all those? No. 96% of the time, the shadow, the spot, the nodule turned out to be nothing. Was it highly specific? Meaning if you had a normal CT scan, were you likely to have cancer? No. So the CT scan was very specific, meaning that if you had a normal scan, then there is no chance you had lung cancer. But if you had a positive scan, there was only a 4% chance you had lung cancer.
Say that again.
Yeah, if you had a positive CT scan, of the 100 patients, say, that turned out to be positive, only 4 out of those 100 ended up with lung cancer. The other 96, of which I happen to be one, had lung nodules that stayed stable over the course of time. So if you have a nodule in your lung that's identified, a shadow, a spot, or whatever you want to call it, then the recommendation is to get another scan in 3 months. Then get another scan in 3 months. So now you got 3 CT scans. Then you get one in 6 months and one in a year, and you continually follow it until a course of time has passed where you feel comfortable saying, it hasn't changed, I'm okay. Is it readily available? Yep, it is. You can get a CT scan any time of the day or night. You can get them anywhere you want now. They'll even come to your house and do them. They really will. Is it yeah, they really will. They have a portable CT scan. You can call, you can schedule it, they'll come to your house and do your CT scan. You don't even want to know what it costs. But is it inexpensive? Not hardly. Is it safe? Does it cause no harm? I don't think so. We know that a young child under the age of 1 who gets a CT scan of the abdomen, for whatever reason, maybe a little baby in a car seat is in a car accident, gets a CT scan, they have a 50% higher risk of developing ovarian cancer over the course of their lifetime. From one CT scan at the age, under the age of 1. So I don't think they're safe. Well, we know that CT screening saves lives, but there's still a lot of questions. Okay, we know that Medicare has said they're going to begin to pay for it. They are. And we know that patients who have Obamacare are also covered. But most of the people with Obamacare are younger folks. They don't get lung cancer anyhow, so they don't really need to be screened. So let's take that group out, because they're not really going to be a major contributor to this problem. But Medicare certainly is. Medicare, for all intents and purposes, is insurance of the elderly. But I'm soon Medicare age, so I'm not saying it's elderly anymore. But we know that Medicare, people in that Medicare age range are the ones that develop lung cancer. They're not the 18-year-old college student with Obamacare. What about other insurers? What about Blue Cross Blue Shield? What about Aetna? What about, Health Choice? What about all these other things? Well, nobody knows. Well, who's going to pay for it? It's estimated that 50 million people in the United States will need a CT scan whenever this all kicks in. And I just said maybe $1,000 a shot. When I had mine done, I paid $2,600 for my CT scan. And that wasn't that long ago. But I'm just conservatively saying $1,000. That's 50 billion. That's a B, not an M. That's a B per year. 50 billion per year, just on the scan alone, not the treatment. And then if you have an abnormal one, then you gotta get another scan in 3 months. And then you gotta get another one in 3 months, and another one in a year, and another one. And this goes on and on. It is not cheap. Well, who should be screened? Well, how about all smokers? Well, what if you're 32 years old and you smoked for 10 years? What are your chances of having lung cancer? Pretty darn low. What if you never smoked? What age should you start? 60? Well, I'm not 60, and if I were a smoker, I'd like to get it. I'd like to have my scan. How many packs a day do you have to smoke? What if you only smoked a half a pack for 50 years? Is that the same as smoking 1 pack for 20? Nobody knows. What about your family history? What if your wife or husband, your mother, father, brother, or sister had cancer? Does that matter? What do we do with all those positive CT scans? I told you that 95% or thereabout are not going to turn out to be anything. Who's taking care of all those patients? What do you do with them? How often should screening be done? Should you do it once a year, twice a year, every 5 years? Who knows? might screening encourage smoking? If I knew that I could go get a CT scan that was going to find my cancer at a stage 1 where it was easily treated, well, I'll just go smoke then. Some people might say that. I mean, I wouldn't, but some people might. And one of the arguments has been, well, this is just going to promote more bad behavior because now we're going to go find that bad behavior result, that is smoking. We're going to find the consequences of it earlier, and we're going to take care of it, and we're going to treat it. Well, then everybody might as well just smoke. Is there really a safe dose of radiation? Do you want to get it? I don't want it. I don't want radiation of any kind. So when I had my lung nodules, I just said, look, I know they're probably benign. I wouldn't tell my patient that, but I'm not getting another scan. I'm not going to do that. I'm not getting exposed. What about non-smokers? Well, we said a large percentage of people with adenocarcinoma of the lung don't get cancer. I mean, aren't smokers. What about those? And what about those slow-growing cancers? You know, the one that you see on a scan and you tell a patient, look, you need to come back in 3 months, and they walk a while and they never show back up for 3 years, and they come back in 3 years, and now the tumor is maybe a little bit bigger, maybe. But in the meantime, they've had 2 heart attacks and a stroke, and they're not really in good shape for anything. Well, they want something done, so you do a biopsy, and it turned out it was cancer. Well, that kind of tumor is never going to harm anybody. It didn't matter if we found it or not, because they were going to die of other medical problems before they ever died of their lung cancer. So what about those slow-growing cancers? And we can predict the growth of some of these tumors. But should those people, should that be part of it? You know, I mean, again, does it make a difference if you find a tumor at an early stage whenever the patient is never going to be harmed by that tumor? What difference did it make? I mean, you can say, okay, you do have lung cancer, but you know what? It's not going to bother you. So again, who answers all these questions? Well, we know that's, like I said, screening for colon, breast, and prostate cancer is widely accepted. We know that CT scanning saves lives. We can work on all those other issues that I just went over. And now what I want to do is I want to go over some of the things that we're doing here at ARMC that I think are pretty exciting and are really going to change what we do for lung cancer. All right, I'm going to talk about 4 things. ENB, electromagnetic navigational bronchoscopy. You see why I just call it ENB and not all that stuff. VATS, video-assisted thoracic surgery. SBRT, stereotactic body frame radiotherapy. And RFA, radiofrequency ablation. I'm going to go over all those because they are all here, they're all available, they're hot off the presses, they're the most rapidly growing parts of technology. We have them here. All right, well, here's the problem. In the old days, when you had a tumor in your lung, a doctor would put a telescope down inside the lung, and it could go, you know, somewhere around this area, because this thing is pretty big. I mean, it's about as big around as my finger. It's got to go down through your nose and through your voice box and out into your lungs. Well, how do you get to that tumor right there? Or how do you get to that tumor down there? You just can't do it. So why did it make a difference to find this little tiny tumor here if I can't do anything about it? I can't diagnose it. I can't even reach it. Well, that's where ENB comes into play. This uses a standard CT scan, and just like the GPS in your car, it'll tell you exactly where to go, and it'll allow you to get to these lesions at a much smaller area, a much smaller size, so that you can actually find them. So with this ENB, you put this tube down there, and again, it only goes to here or here, it won't go any further, and then you snake this little thing out, and the machine says, make a right, no, pull back, make a left, pull back, and it'll tell you exactly where to go, and I'm going to show you how it works.
The Superdimension InReach system provides electromagnetic navigation and access to multiple locations in the lung and mediastinum. To facilitate transbronchial needle aspiration of mediastinal lymph nodes, the physician positions the tip of the steerable navigation catheter, or locatable guide, via the CT images, and creates a small dent at the lymph node entry point. The cytology or histology needle can then be inserted into the lymph node and sample collection completed. To access peripheral lesions, electromagnetic guidance is achieved through a sensor incorporated into the distal tip of the steerable navigation catheter. Together with the InReach guide catheter, or extended working channel, the catheters are inserted into the bronchoscope's own working channel. When the bronchoscope cannot proceed anymore, the steerable navigation and guide catheters are advanced and steered by turning and pulling the dial on the catheter handle. The location and steering directions are performed according to the sensor's position on the CT roadmap relative to the target, which was previously registered to the patient's lung. When reaching another airway bifurcation, the catheters are again pushed forward and steered by manipulating the handle. After reaching the target, the guide catheter is locked in place and the steerable navigation catheter is removed. The guide catheter now serves as an extension of the bronchoscope channel, providing the physician a pathway leading all the way to the target. Through this channel, endobronchial tools are inserted for collection of tissue samples. The InReach system provides a minimally invasive tool for accessing peripheral lung lesions and mediastinal lymph nodes. Timely diagnostic and treatment decisions of lung disease are possible even in patients with procedure-restricting conditions.
Okay, you see how that works? And it actually does tell you, it does say make a right, no, pull back, go this way, go that way. I somehow have lost my, there we go, okay. So that's E and B. Where am I at here? All right, what about VATS? I'm not going to make this bigger, but VATS is video-assisted thoracic surgery. Again, this is using these highly sophisticated robots and computer screens. We can now do surgery of the chest with little tiny incisions. And let me show you a picture of that. I'm just going to show you one because we're running out of time, but this is what it looks like. This is done by, not me, but could have been. We do this every day up in the operating room. So here's the tumor in the lung. This is the right lung. There's the tumor they're going to go for. This is the heart right here. So here's a little tiny incision big enough to put your finger through. You put this, what we call a port. This is what it looks like on the inside of you. There's your lung. These are the ribs here. Anybody like ribs? I can't eat them. But that's the muscle that you eat whenever you go out and order ribs. So again, he'll put his finger in there. There's your finger going in the chest cavity. Someone's running the camera while you're actually doing the surgery. Now they're going to try to fill it with a clamp. They put a clamp in there and just sort of run it over the lung, trying to fill for this tumor in the lung. And there you can see it. Now he's going to try to get his finger. He's pushing, saying, come on, push it up here. Let me see if that's it. Fill it. I want to fill it. So now he's trying to fill it. He's got his finger in there and fills the thing. Says, okay, that's it. I guess that must be it. Don't you just love the music?
Yeah, I'm like.
Aren't you all excited to see what really happens here?
Don't anybody else are screaming. So
this is what we look at, this is what we see. This is a stapling device. This actually was going to staple that tumor out of the lung that he felt with his finger. You can see the thing sticking up there a little bit. So here's the staples in the lung. They're actually going to staple this right out of the lung. Almost got it. There's a pair of scissors. And then you put it inside this bag because you don't want to lose it. And you put it in this bag, and then you pull it out in that bag. Okay, you got it? You got the idea how it works?
Looks like you're working in a coliseum.
Yeah, how about that? That's pretty cool, huh?
That is.
All right, well, that's what we do for video-assisted thoracic surgery. So you can see if you had a little tiny tumor and you could fill it somehow, or you could do something to mark it, how taking this out through a little tiny incision would be a good thing. You could get the patients back to work less than a week, be a good thing. All right, what about this thing called, we're almost done. I know it's a little past our time, but we started a little late. SBRT, this is pretty cool. Stereotactic body frame radiotherapy. This also uses GPS, and I'm going to show you that. But this time it uses radiation therapy. And the reason is when you have lung cancer, the way you get treated now, you stand in front of the machine 5 days a week for 6 weeks. The radiation fires a shot at you, goes through your skin, through your pectoralis muscle, through all your breast tissue, you know, to get to the tumor in the lung. Well, your breast had to receive more radiation than the tumor did. So you're frequently limited by how much radiation you can give the lung by the breast or the heart or whatever else may be in the way, depending upon where the tumor is. But with this technique, which I'm going to show you, this uses a computer to track the location of the tumor. And let me show you that here, okay? Again, this is a cartoon, but
radiation treatment consisted of single large doses of radiation that damaged the DNA within the cancer cells of the tumor, thereby killing those cells. However, those large doses of radiation also traveled through the surrounding healthy tissue, exposing normal cells to a significant amount of radiation and killing them as well. The CyberKnife stereotactic radiosurgery system uses computer-assisted, non-surgical technology to transmit small beams of radiation from several different angles into a tumor, thereby minimizing the exposure of surrounding healthy tissue. Based on CT scan data of a tumor and the skeletal structure of the body as a reference frame, a high-speed computer-controlled robotic arm is used to track patient and tumor positions during treatment. Instead of one large dose of radiation, the CyberKnife's robotic arm can maneuver and emit single, small-dose radiation beams that can enter the body from up to 1,200 different angles. The goal is to maximize tumor exposure by hitting the tumor with greater amounts of small-dose beams. All the while, the surrounding healthy tissue remains unaltered, because radiation beams that travel through the healthy tissue consist of such a small dose of radiation. The CyberKnife stereotactic radiosurgery system is an entirely new approach to radiosurgery that eliminates the need for a rigid stereotactic frame, enables painless treatment of tumor sites anywhere in the body, and can still be done on an outpatient basis.
okay, does that make sense how it works? So here's the problem. Whenever you're laying there on the table and you take in a deep breath, all of a sudden the tumor, which was exposed to the radiation, has moved because now I've taken a breath and my lung moves every time I breathe. But what this thing does is it follows the tumor as I breathe, as my heart beats and things like that. So it actually tracks it in time. And so as it fires all these X-ray beams down at the tumor, they sort of all intersect right where the tumor is. And as it said, 1,200 different ways to fire the X-ray beam in there so that no single part of the body gets a high dose except for the tumor itself. Okay, one last video and then we're done. There's something called RFA, and this is just again, this is
Radio frequency ablation, or RFA, is a non-surgical procedure used to treat cancerous tumors. RFA is most commonly used for tumors of the lung, liver, and kidney up to 5 centimeters in diameter. This minimally invasive procedure provides an alternative for cancer treatment when surgery is not an option. For ablation of a lung tumor, the RFA procedure is performed with the patient lying comfortably in a CT scanner. Frequently, only minimal sedation is necessary. Grounding pads are placed on the patient's thighs during the procedure. Scans are taken before the treatment and at times throughout the procedure to aid in guidance. First, a CT scan is taken to locate the tumor.
So here's the tumor right here.
A lidocaine shot is given to numb the area. This may feel like a bee sting. Radiofrequency ablation kills cancer cells using heat on the end of a probe created by an electrical current at radio wave frequency. The RFA probe is placed directly into the tumor. Multiple probes may be used depending on the size, shape, and location of the tumor to increase the area of effect. Once the probes are in place, current is applied at the end of the probes. This current increases the temperature of surrounding tumor cells, destroying a spherical area of cells around the end of the probe. This area is called the ablation zone. A 1 centimeter margin of healthy tissue is included in the ablation zone. This is to ensure that the entire tumor has been treated. A final CT scan is taken to confirm the full area of the tumor was treated, and the patient may be able to return home the same day. Follow-up visits are necessary at regular intervals after 4 weeks to check the progress of recovery.
All right, so here's the last slide. Then we'll go over the exam, see how you did. CT screening works. It does indeed reduce lung cancer deaths. It finds the tumor at an earlier stage when there's more effective therapy. And we continue to define who, what, when, where, and why we are doing this. Those questions are going to be answered over the next decade or so. However, we know that we do have newer tools that are available, such as ENB, that may improve the accuracy of the CT scan. We know that video-assisted surgery may allow sicker patients to benefit from surgery as it's less invasive. And things like SBRT and RFA are minimally invasive, and they can be effectively used in patients who are not surgical candidates. All of these are available here at ARMC. Again, I started to talk out by saying that lung cancer is a deadly disease, but we are making strides and we're getting better and better, and I do think that the future is bright for lung cancer.